Mr. Chairman, ladies and gentlemen, it's a great honour to be part of this group of professionals talking about venous leg ulcers, wounds, and the crisis of venous disease and how these are all interrelated. I would like to now present my presentation on the crisis of venous disease. I have no disclosures relevant to this presentation. All of us who are involved in the treatment of patients with venous leg ulcers are aware that there is currently a crisis in this area. The difficulty is most people are still putting this down just to a lack of money and not understanding that in fact this is due to many different factors, and it really stems from a crisis in the understanding and treatment of venous disease. And this talk is going to try and highlight these. Firstly, without doubt, there is an increasing number of cases of patients with severe venous disease and venous disease in general, and I'm going to talk about that. There are certainly increasing pressures on finance for health. Unfortunately, there's also very poor education on healthcare professionals in this area, and a failure of those of us who are in this area to follow research and guidelines. When we look at the increasing number of cases, firstly, we are all aware that there is an increasing world population, and we know that this has been a huge increase, certainly over the last 40, 50 and 60 years. However, it's not just a numbers game, because we also know that venous disease gets more prevalent the older people get, and there's also an increasing age of the world population, so more people but also an increasing age of those increased number of people. Compounding the increasing numbers of older people in the world, we also have to look at the increasing obesity both in adults and also in adolescents and children, as it's known that there's a strong association between obesity and the severity, not the incidence and prevalence, but the severity of venous disease. So knowing that we've got more people who are getting older and are getting more obese, and therefore a very large increase in venous disease, we can see that the increase on current health expenditure over all specialities is increasing a little, but it is relatively stable. And we know that there are increasing demands on health budgets because there's so many different conditions that can now be treated. Moreover, even though people are aware that inflation increases, many people, even in the profession, are unaware that medical inflation usually increases by at least double that of the general inflation rate because of the increased price of healthcare. Turning now to education of healthcare professionals, it's been in the last decade that many different countries have started recognizing vascular surgery as an independent speciality. The trouble with this is that although the definitions include venous endovascular surgery, we know that in vascular surgical training, really only arterial surgery is trained. This is because arterial surgery is very dramatic, the operations are very expensive, but the reality is they're very few and far between compared to the number of people who have venous disease. And also they affect very old people, whereas venous disease affects much younger people and has a much improved increase in quality of life if treated properly. And this is a problem with the fact that most education has very little emphasis on venous surgery. One of the things that is most important, however, is that those of us who are actually in the area of treating patients with venous leg ulcers actually are showing a failure to follow research and guidelines. Now, we know, and I'm sure most of you are aware, that approximately 1% of the world population suffers from venous leg ulcers, whether open or healed, and this has been well shown to be quite a stable number. In our own country, in the UK, there's estimated 500,000 people who are open or healed with venous leg ulceration, but the standard treatment is still compression, despite all that we now know about venous leg ulcers, costing the NHS somewhere between £1 and £3 billion per year, depending how you measure it. What is amazing that this is true despite the research and guidelines showing that most of these now could be cured by endovenous intervention. The problem is that we all still follow traditional teaching, and really this is understanding from before the 1980s. In this old understanding, we thought that if you had reflux in the great venous vein or small venous vein, you would get varicose veins, which were only cosmetic. If, on the other hand, the reflux was in the deep veins, then you could end up with a venous leg ulcer, and this was then a serious problem. This same traditional teaching then said that if you did have the superficial venous reflux causing varicose veins, you could have surgery for it to remove it, but it was only cosmetic and up to the patient. On the other hand, if it was your deep veins that were refluxing, there was nothing that could be done about the deep veins, and therefore only compression would help. However, it was right back in 1984 when the first papers started appearing showing that venous leg ulcers were due only to great venous vein and perforator incompetence. And by 1993, it was shown that this was 53% of people with venous ulcers who had reflux in the superficial veins only, previously thought to only cause cosmetic varicose veins. By 2007, the ESHCAR trial had shown in a randomized controlled study that if you treated the varicose veins or superficial venous reflux rather than just compress the veins, you got fewer recurrences of the leg ulcers in the future. In 2013, we published an 85% healing rate of the venous leg ulcers in patients who came to us provided they were walking if we performed endovenous surgery, and this was complete healing with no need for further dressings. In 2018, this very important trial published in the New England Journal of Medicine called the EVRAR trial showed very clearly that if you perform endovenous surgery rather than compression, you get faster healing of the leg ulcers than compression alone. So when we look at patients, we have these different patterns of reflux that are possible in venous patients: superficial vein reflux, perforator vein reflux, combination of both, deep vein reflux, superficial vein reflux and perforators altogether, and just deep vein reflux. We now know that the majority of these can all be cured with endovenous surgery, and even those with deep vein reflux can now be improved with stenting or improved by just treating the superficial component alone. Indeed, research by Ronald Bush has shown that treatment of the venous plexus around the leg ulcer alone will also improve, if not heal, the ulcer. The international guidelines from America, the UK and Europe all state that if you have venous leg ulcers secondary to superficial vein reflux, you should have these treatments. And so in conclusion, there are increasing numbers of cases, and the only thing we can change about this is to help reduce the obesity by health education. It is highly unlikely we will get any increase in funding, but we must start increasing the education of healthcare professionals. We must all be aware of the research and guidelines in this area, not only be aware of them, but must follow the research and guidelines.